Lisa walked into our clinic hours after being released from prison. These were the facts. 10 years in prison, 10 years separated from her children, multiple failed rehab attempts, felon, armed robbery under her belt. But when we asked more questions, such as, why the pain, not why the addiction, we learned so much more. Lisa's inner voices needed her to numb out. Her history of sexual assault led her to a place of heroin addiction. The external voices kept her there. Rehab told her, you will never succeed. Landlords told her, you will never live here. Employers told her, you will never work here. These are the voices of the systems we have created. Lisa internalized these voices, and this only amplified the shame that she already carried. Lisa's story is not unique. In fact, it is the norm. Dr. Brené Brown describes shame as the intensely painful feeling or experience of believing that we are flawed and therefore unworthy of love and belonging. We have all experienced shame before, and it's awful. At some levels, our systems of support impose shame on people using drugs. Housing, healthcare, criminal justice, social welfare, rehab. And people struggling with addictions often hold shame at a far greater level than the rest of us. So it's on us. Let's talk about what we've created as a society. Our US history has over 100 years of laws reflecting attitudes and stigmatization of people struggling with addictions. The official war on drugs began in the 1970s when President Nixon declared drugs public enemy number one. Every single president since has intensified the war on drugs. A cornerstone of the war on drugs is the mass incarceration of people who use drugs. This is an effect that will impact the lives of generations to come. 1 in 5 Americans who are in jail are locked up for a drug offense. On any given day, 450,000 Americans are incarcerated for nonviolent drug offenses, things such as possession of marijuana, heroin, or cocaine. More Black men are under correctional control today, in prison, in jail, or on parole, than were enslaved in 1850. At the height of the war on drugs, possession of just 5 grams of crack cocaine gave people the same sentence as possession of over 500 grams of powder cocaine. Crack cocaine was a cheaper form of cocaine, often found in poorer communities, where more Black and brown people lived. It took 24 years to reduce the disparity in sentencing for crack and powder cocaine, and it took 24 years to lift the mandatory minimum 5-year prison sentence. What happened to communities over those years? Intergenerational trauma is untreated trauma that is passed down from parent to child, from their connection or lack of, and from messages about self and other, safety and danger. Indigenous cultures have known about this and taught about this for decades and centuries. Science is only now finding the evidence for it. Another layer are issues around land, culture, loss of land, and loss of culture that are prevalent in many communities in the US. Our systems of care in the US often do not acknowledge or recognize these causes and layers of complexities. So let's go back to Lisa. who suffered 10 years in prison, 10 years of daily worsening, traumatizing, post-traumatic stress disorder symptoms, PTSD, 10 years of no autonomy over her body and her decisions, 10 years of her children growing up without her. Add to that the intergenerational trauma that she faced living in her family and the community that she grew up in. The institutions of criminalization have failed people struggling with addictions, but many of those same attitudes and stigmas are present in our institutions of healing. From medical experimentation on slave women to the infamous Tuskegee study, where Black men went untreated for syphilis, to sterilization of Latina women, we have a dark history in healthcare. And we have problematic relationships with race, stigma, and morality. Addictions are no exception to that. During the cocaine and crack epidemic of the 1980s, women who were pregnant and addicted to crack were often criminalized and sent to jail, and their babies were separated from them. They were not offered support or nurturing. Years later, it was acknowledged that these kids, who were formerly called crack babies, had no significant permanent developmental or other long-term effects of being exposed to crack. But they grew up without their families. A recent study shows that Black patients who tested positive on urine drug tests for illicit drugs were discharged from treatment at a far higher rate than white patients with the same. In addition, neighborhoods most in need of healthcare and drug treatment centers are those often systematically denied those resources. That being said, there's been a lot of progress in the way the medical community approaches addictions. For one, addiction is now seen as a medical illness and not as a moral weakness. And there are effective medications, things such as buprenorphine, commonly known as Suboxone. This medicine binds to the same receptors that heroin or opioid pain pills bind to in our brains, calms cravings, and provides a protective shield against heroin or opioid pain pills. Many people refer to Suboxone as a life raft or a warm hug. For once, they are not thinking about where they're going to get their next fix, if they're going to suffer painful drug withdrawals, or how they're going to be present for their families. And Suboxone reduces overdose death rates by over 50% in people who are struggling with opioid addictions. This medication is easy to prescribe. It literally gives people life. It allows people to smell the flowers, feel their emotions, and reconnect with their families. Sounds easy. Why are we not prescribing more of it? And yet, only 1/3 of drug treatment centers in the US use Suboxone or another medication, methadone, for medication treatment. Only 7% of doctors are licensed to prescribe Suboxone in the US. And more than 80% of people struggling with opioid addictions in the US are not being treated with these medications. Also, white Americans are 35 times more likely to have a visit with a clinician for Suboxone than Black Americans. And Black Americans are dying at equal or higher rates from opioid addictions. Judgment and shame continue to also play a part in our work. If someone has type 2 diabetes and needs insulin, I don't withhold the insulin from them unless they go out and exercise and get on a diet. However, in the world of addictions, there are often very rigid rules in many drug treatment centers and outpatient clinics that force people off medications. For example, Lisa was kicked out of one treatment program because she tested positive for cocaine. She was kicked out of another treatment program because she missed 2 counseling appointments. These kinds of actions have deadly consequences and push people further into shame cycles. So where do we go from here? If we're trying to dissolve a culture of shame, we need to be building a better culture. We can all be cultural workers together. We come from 2 organizations. Casa de Salud is a primary care clinic, and Centro Savila is a behavioral health clinic, both situated close to each other. We are deeply rooted in our community, and we serve those around us, many folks who've dealt with oppressions and racism. We work together to support people struggling with opioid addictions. We know we have a responsibility to acknowledge the harms and neglect that the medical community has imposed on our communities of care. And we know we must do better. We took a fresh look at the issue and decided that all of our services would fundamentally be about changing culture. First, we must begin with language and stigma. At the core of everything is how we talk about addiction, because how we talk about addiction is how we think about it. We need to change our language. Addict, frequent flyer, disorder, clean or dirty, we don't talk to our patients like that. We treat our patients as leaders in the community, and we know that we are better off because of them. We acknowledge their resilience and their incredible strength. We call on clinicians to check our own biases. What we do and say affects others. And we stop and listen. This simple tool allows for some time for reflection, allows changing of perspective, and allows the right words to come out. This is something all of us can do, whether working in the medical community or not. We can all reflect on our biases and engage with friends, family members, community members to call out stigmatizing language and the ways in which people who use drugs are talked to and talked about. Second, we must meet people where they are. We come from a harm reduction perspective, which means simply meeting people where they are. If someone's using drugs, how can we help them use safely so that they're alive, and then provide other options for their care? Casa de Salud has an active syringe exchange program. People bring in used syringes and exchange leave with new syringes, and education about how to use more safely, how to decrease transmission of infections. And in fact, what we found is this, that if you treat people with dignity and meet them where they are, their shame falls away. They're able to open up about other needs that they have, and they're able to pursue things like primary care, pursue things like treatment, and feel at home and safe. Through the syringe exchange program, we also distribute Narcan, a powerful opioid overdose reversal tool. This medication is something that someone can provide to someone else if they are overdosing. We've now in New Mexico had a tremendous response to this tool. 1 in every 3 units of Narcan that is distributed to the community is used to save someone's life. This is staggering. The ability for people to save each other's lives in this profound way outside of any healthcare center, in people's homes and in their communities. We can all advocate for more systems of harm reduction, or just for a reframe on how we meet people where they're at. Third, we must design responsive treatment and recovery options. Inclusivity is not just about including, it is about belonging. That sense of belonging is something we know that we have to provide in our spaces of healing. We threw out convention and designed a program which was built around providing medication and integrative healing options and love and dignity and respect. Our work combines medication, body work, energy work, and what we call soul work. A clinic should be a place where patients can start to heal themselves at their own pace. We follow the teachings of the promotoras tradicionales, Calpulli Iscali, who say, honor the wisdom of our ancestors and recognize the traditional and natural ways in which people participate in their own healing. We know that trauma is held in our bodies, and we do work to help release that trauma. Let's come back to Lisa. Lisa has received treatment numerous times with Reiki, an energy healing medicine from Japan that we use in our clinics. With Reiki, she has been able to reduce her anxiety, sleep better, and feel less frenetic about her energy. These in the past were triggers for her to use heroin. She goes to our acupuncturist, where she's treated for her low back pain that was a result of an old car accident. Her back pain used to be a trigger for her to use. Now she has tools to deal with that. She attends our healing circles, which follow a native tradition of holding a sacred feather, and the person who holds that feather speaks for that time uninterrupted. That is a safe space, a place where patients are able to share what they're going through, teach and learn from each other, and heal together. She also is treated with dignity and respect from her counselor, and she was able to find permanent housing with the support of her case manager. The fact that Lisa could choose which of these options and healing modalities she wanted to pursue for her own healing at her own pace, it was the first time that she felt that she had autonomy, agency over her own life, and choice. This was really powerful. We encourage healthcare spaces to go back to the drawing board and think about, one, how we can redesign how we provide healthcare and healing to the communities that we love and serve. And two, to think about what barriers we are inadvertently creating for patients who are in this moment finding this strength to take this step and seek treatment. Drugs are readily available in all of our communities. Lisa knows that she can text a heroin dealer, and within 30 minutes, she'll have heroin delivered to her front door. Every day she chooses not to do that and chooses treatment. We need to make healing and healthcare that rapidly accessible. Fourth, author Johann Hari quotes, "The opposite of addiction isn't sobriety, it's connection. Purpose and belonging are everything." These are lessons we are learning in healthcare, but these principles apply to all of our systems of support. Lisa remembers walking into a talking circle one day and being told, "Welcome, leader." This was an entire reframe for someone who had been treated by the medical community and by every other system that she faced as a morally weak person, a criminal, or a powerless victim. Here, in our talking circle and healing circle, she stood a bit taller, she projected her voice more, straightened up her shoulders. We saw her build her confidence. Now Lisa is in her second year free of using heroin. Her kids live with her. She was just able to see her son graduate from high school. She is a leader in her community and has spoken at numerous community events and has even helped to design and implement a set of workshops that she and other peers are giving to other folks who struggle with drugs in our community on the roots of addiction. This is really powerful. She is a cultural worker in her own right. And now she is pursuing a certified peer support certification so that she can dedicate her life to helping others who are struggling with addictions. We really can do this. It's not rocket science. It's about creativity and love, language and reducing stigma, building purpose together, connection, community, all human things. And in healthcare, building evidence-based practice and what we call practice-based evidence to transform shame into healing and pride. It's about bit by bit transforming our systems. Together, we can dissolve this culture of shame. When we treat people like they're worth it, they start to treat themselves like they're worth it too.